We'll go ahead and get started. So welcome everyone to my Section GG webinar. Today is recorded, so just so you know that for any questions you might ask, it is going to be recorded. But if you ask a question that's sensitive that you'd like me to remove from the recording, just let me know and I will be more than happy to edit it out. So I am Clarice Grote. I am the founder of Amplify OT. Too far. So I'm an occupational therapist by trade. I've experience in home health, acute care, and hospital-based outpatient. I now do this full-time though, so I am the founder and CEO of Amplify OT, a company I founded to try and make Medicare information more easy to access for occupational therapy practitioners, and to make sure that we have a voice in this space. I'm also the former director of practice for the Missouri Occupational Therapy Association and the former advocacy and policy coordinator for AOTA's Home and Community Health SIS, which is a large part of how I got into this and got this experience working in policy and advocacy. And I am currently an AOT PAC ambassador for the state of North Carolina, which is where I currently live. And that's my email address as well as my website, which is how most of you probably found this webinar. So to start out, we're going to first talk about who is CMS. So this is going to be a large part of Section GG. So CMS stands for the Centers for Medicare and Medicaid Services. So CMS is in charge of determining the rules and regulations that govern Medicare. They set the guidelines for reimbursement under Medicaid, even though Medicaid is still largely determined by the states. CMS does set a general framework. They develop new and innovative payment models, and regulation is largely determined by Congress. So oftentimes, because Medicare is a federally funded program, their regulation is primarily determined by Congress, which is how we found Section GG. So Section GG is here because of the Impact Act of 2014. So this bill required development of specific quality measures for post-acute care. So the whole effort was to standardize the way that we collect information and assess quality in post-acute care settings, which obviously has a lot of therapy practitioners working in them. So there's 5 main quality domains that they wanted to be created: functional status, cognitive function and mental status, impairments, medical conditions and comorbidities, special services, treatments, and interventions. So there's been a long journey towards standardization. And so as you can see, standardization started way back, starting in the 1992. And then as they've been moving forward, CMS has been continuing to improve standardization within the post-acute care setting, within Medicare in general, to try and provide a better picture of how patients are actually moving through the care continuum. And that's where we kind of have Section GG today. It really hasn't been all that long since Medicare started even just assessing the quality of care in these settings, because even the OASIS didn't start until like the late 1990s. And so this hasn't been a very long journey where we've been assessing quality, so we're still learning a lot. So how does Section GG fit into reimbursement, and why is it important? Because reimbursement impacts all areas of practice. So when you're thinking about the big picture, reimbursement is impacted by quality care initiatives. It's also hospital length of stays are heavily driven by reimbursement. There's a drive to reduce wasteful spending in healthcare systems, especially here in the US. And then reimbursement has also been really pushing this idea of value over volume. Now, for the occupational therapy picture of how does reimbursement impact us as a profession, it impacts the amount and the length of visits that we're able to provide. It impacts the type of procedures that we're able to provide. Productivity requirements, often heavily influenced by reimbursement, job availability, and then the types of interventions as well. So reimbursement influences just about everything that we do here in the United States as part of our healthcare system. So what did we have before Section GG was in place? So each setting had its own data and rating scales. So everything was completely different. There is no way to track improvements across settings. So there's no way to see how, Mrs. Jones did in inpatient rehab and how did that compare to how she did in home health. There was not a consistent way of measuring that. So CMS said it was like comparing apples to oranges versus apples to apples. And every single post-acute care setting was completely different in how they assessed these items. And so they wanted a universal language that conveyed functional abilities in order to track patients as they moved through the care continuum. So where and how is Section GG used? It's used in all post-acute care settings. So that includes long-term care hospitals, inpatient rehab facilities, skilled nursing facilities, and home health. So when I say post-acute, I mean those 4 settings. So what you'll notice is left out is pretty much hospitals and outpatient clinics, as well as hospice and palliative care. So those 4 settings right there are your post-acute care settings. Now, Section GG started in 2016. It was first introduced in long-term care hospitals, and it's still used there with only a smaller portion versus the full Section GG is used in the other settings. And it didn't reach home health until 2019. So again, it's still a fairly new assessment that CMS introduced. It took a little while for them to get it through. And again, this is another poignant reminder that it's really important to get involved early, because if you'll remember, the Impact Act was in 2014. So we're still seeing the effects of the Impact Act, even though that passed almost 10 years ago, and then it's taken this long time for us to get Section GG. So this is why advocacy and getting involved early is so important, because often, especially when it comes to government and comes to Medicare, decisions get made slowly over time. So the earlier we're involved, the more control we have over the situation. It's completed at admission and discharge at a minimum in these settings, and it's included and required as part of the LCDS, the IRF-PI, the MDS, and the OASIS. So it is now fully implemented in all of those admission and discharge assessments that Medicare requires. It influences reimbursement directly in inpatient rehab and skilled nursing facilities. So accurate scoring on Section GG is essential in those settings, specifically because it directly influences how much the facility will get paid from Medicare based on those scores. It also directly influences quality measures, predominantly in inpatient rehab facilities and skilled nursing facilities. So why is accurate scoring important? Well, it informs clinical data and coding. So this is one of the main snapshots that it gives CMS of how a patient is doing and the impact that therapy has directly on these patients in these settings. It gives us a picture of a patient's function and their mobility across the care continuum. So remember, instead of comparing the apples to oranges to bananas as they move through, we're now able to look at one standardized way of assessing a patient's self-care and mobility as they move through. So this is another data point where it gives CMS an idea. Naturally, we expect a patient to have a slight decline whenever they change transitions of care, but it looks really odd if someone is scored as min assist in inpatient rehab, and then all of a sudden, 10 hours later, they're scored as max assist in skilled nursing facilities, right? That would potentially trigger some red flags with CMS about if someone is kind of altering the data. So this is a way that they're able to track how a patient moves through the continuum of care in a standardized way. It also is important for accurate reimbursement. So it influences reimbursement under PDPM, the patient-driven payment model, which is in skilled nursing facilities, and it replaced the FIM, or the functional independent measure, in inpatient rehab facilities. So if you've worked in inpatient rehab facilities for a while, or you're not new to them, you may have remembered that the FIM was previously used and required by Medicare in inpatient rehab. The FIM is no longer required. Some facilities may still elect to use it, but it's no longer built into the IRF-PI. Instead, Section GG has now replaced the FIM in inpatient rehab facilities and is now used for determining reimbursement for that functional score. It's also really important for accurate outcome reporting. And so many of these facilities do have quality measures that are directly tied to Section GG scores, which again is why it's important, especially as we continue to see the expansion of value-based purchasing, which is where Medicare provides monetary incentives to provide high quality care. So if something isn't scored accurately, then it's not going to accurately reflect the quality of care that's being provided, which means your agency may not be receiving accurate scoring and also may not be receiving the sufficient reimbursement that they're requiring. It's also a really great way to demonstrate the value of occupational therapy in an objective way, right? We know that occupational therapy has value. We know that we help influence patients' outcomes, but this is a standardized and objective way of tracking it. And because it's completed on every patient in skilled nursing facilities, soon potentially to be completed in every patient on inpatient rehab and home health, it's a really great way to track what influence therapy has on these patients. And it's also a great tool that we can use individually to assess how patients are doing and be able to demonstrate that to our employers and say, hey, for these patients that I saw, these are the improvements from the admission to discharge on Section GG. So it's a really great opportunity to highlight the value of occupational therapy because it's a self-care and mobility item. So there are 4 main sections to Section GG. There's the GG 100, which is prior functioning. So this looks at everyday activities. It has 4 questions. It talks about self-care, indoor mobility, stairs, and functional cognition. The next section of GG is 110, which is prior device use. And this is a check all that applies kind of section. And so they have multiple different devices like walkers, motorized wheelchairs, lifts, etc. And so you're supposed to check all that apply that patient has used. Those two items are primarily used in risk adjustments for payments and quality measures. Next, we have GG 130. So this is self-care, and GG 170, mobility. Now these sections have multiple items and they're labeled by alphabet number. So as you can see, self-care has items number A through H, and mobility has A through S. So mobility is a much bigger section, but on some patients, you're not going to be completing all those items. So how are they used in each setting? So in SNF, inpatient rehab, and long-term care hospitals, you complete the GG 100 and GG 110 only at admission, which makes sense. You're just trying to establish a baseline function. And then you score 130 and 170, both at admission and at discharge. And so that's the same for those three settings. Versus in home health, it's a little bit different just because the OASIS is different. So for abbreviations, SOC stands for start of care, and ROC stands for resumption of care. So in home health, the GG 100 and 110 is completed at the start of care as well as the resumption of care to establish that baseline function. And then GG 130 and 170, self-care mobility, are completed both at the start of care, resumption of care, follow-up, and discharge. And so when we see some of those quality measures in inpatient rehab and SNF, where they're talking about the change in their function, that's where they're looking at the scores that they had at admission and the scores they had at discharge, right? And that's a great way to show the benefits of therapy, is looking at how did they score on these items at admission and how did they score after therapy intervention at discharge. So in the self-care section, these are the items. We have eating, oral hygiene, toilet hygiene, wash upper body. This one, D, is only utilized in long-term care hospitals. It is not utilized in other settings. Shower, bathe, self. This one is used in inpatient rehab, SNF, and home health. So this kind of replaces the wash upper body. They decided not to use this one in long-term care hospitals because most patients are not able to bathe their lower body. So they just use the wash upper body in long-term care. Then we have upper body dressing, lower body dressing, putting on and taking off footwear. And I'll show you a section GG handout that AOTA has where it kind of helps you understand which items are scored in which settings, because long-term care hospitals have a shorter version of section GG as compared to the other settings. Now in mobility, we have quite a few different items. We have rolling left to right, sit to lying, lying to sitting on the side of bed, sit to stand, chair to bed to chair transfer, toilet transfers, car transfers, walking 10 feet, walking 50 feet with 2 turns, walking 150 feet, 4 steps, 12 steps, picking up an object, wheeling 50 feet with 2 turns, and wheeling 150 feet. Now, for some of these items, you might not score them on every patient. For example, if a patient is only a wheelchair user, you would only score the wheeling items and not the walking, versus if they don't use a wheelchair, you would only score the walking items. And CMS does have very clear instructions on when and how to score each item. So the nice thing about section GG is that it has a standardized scoring system. So if you're familiar with any of these admission assessments that CMS uses, they tend to have very different scoring items on every single question. So like even if you looked at the OASIS, right, the OASIS still has a self-care section. They have an ADL section, but every single item has a different scoring system, right? And so one item might have a 0 through 3, one item might have a 0 through 6. So the nice thing about section GG is it has a standardized way of assessing each individual item within it. So no matter if you're scoring a self-care A, eating, or you're scoring a mobility item, you're still going to use this 6-point scale. Now, what's important to remember, especially with the OASIS, is that the 6-point scale here is inverse of what home health is. So like in home health, a 0 is most independent, versus in section GG, a 6 is most independent. So if you're responsible for scoring these assessments, it's really important that you pay attention and know that there are some inconsistencies within the own assessment of how these items are used. So you don't want to be scoring someone as independent in one and then dependent in the other because you didn't know that some of the scoring was inverse. So this is section GG scoring. So a 6 is independent, meaning that the patient or resident completes the activity by themselves without any assistance. So that includes setup, no touching, no verbal cues, anything like that, fully independent. 5 is setup or cleanup assistance. So this is where the helper sets up or cleans up, but the patient or resident completes the activity. So this means that the person is only helping prior to or following the activity. So if the patient is sitting on the edge of the bed, it's time to put on their shoes, and they say, hey, can you go grab those shoes in the corner for me and bring them to me? That would count as setting up assistance. Now, if the patient's able to walk over there, get their shoes and bring them back to put them on, then that might be more of an independent. And so it's important, to keep that in mind when you're scoring these items and assessing them, that setup and cleanup is its own score. The next one is supervision or touching assistance. And this is where things get a little bit tricky for us as therapists because we're used to using, right, contact guard, min, mod, max, dependent, right? This is where it gets a little different. So CMS combines standby assist, contact guard, and min assist all within this number 4. So number 4 is a supervision and touching assistance, meaning that the helper provided verbal cues, touching or steadying, or contact guard assist as they complete the activity. And assistance may be provided throughout the activity or just intermittently. So this is where they kind of combine it. And CMS, I believe, just made this decision just because contact guard and min assist, it's pretty similar in terms of when you're looking at a patient's function and reimbursement and therapy needs. So they didn't feel the need to stratify those two out. The next one is your partial or moderate assistance. And this is where the helper does less than half the effort. So the helper lifts, holds, or supports trunks or limbs, but provides less than half the effort. So this might be somewhere where we're actually scoring that min assist or something kind of close to mod, right? And so thinking about that, are you completing half the effort? And that includes, setting up and lifting and all that sort of stuff, and you're scoring the complete task. The next one is substantial or maximum assistance. So helper does more than half the effort. So that kind of, again, crosses that line of mod to max. The helper lifts or holds the trunk and limbs and provides more than half the effort to complete the task. Now, the last one is dependent. And this is where the helper does all the effort, the patient or resident does none of the effort to complete the activity, or 2 people are required in order to complete the task safely. So if you are co-treating and you feel that 2 therapists or 2 individuals are necessary to help that patient complete the activity safely, then you're already going to be scoring a 1 dependent. So that's another important factor to remember. Besides the 6-point scale, we also have what are called ANA codes, or activity not attempted codes. And these are codes that you want to try and use as little as possible. So we have 0.7, which is that the resident refused. We have 0.9, not applicable. So the resident did not perform this activity prior to the current injury, exacerbation, or injury. Oh, it says that twice. 10 is not attempted due to environmental limitations. So these are some examples from CMS. This one they feel really rarely should be used. It's really only for, like, let's say the facility doesn't have a wheelchair large enough to accommodate a patient's body habitus, and you aren't able to score a wheeling section. That would be something where you can't complete it due to an activity or environmental limitation. Or if there aren't any uneven services within the facility, another option where you can't complete due to environmental limitations. The CMS does state that this one should be used as rarely as possible. And then 88 is activity not attempted due to medical conditions or safety concerns. And we'll talk about this one a little bit, but again, there's a lot of ways that we could be able to avoid the 88 not attempted based on how CMS allows us to score and assess these items. So how to score? So direct observation is key, and that's the primary way that CMS prefers these items to be scored, but it's not the only way. And so this is where it's really helpful to have therapists participate in Section GG scoring, because many of the items, as you saw in Section GG, are things that we're already doing as part of a standardized evaluation. And so it's easier for us to be able to have them do these activities, be able to also score Section GG and provide a more accurate score, because oftentimes we are observing patients directly doing these tasks. Now, if we aren't able to provide direct observation of the patient actually eating or completing oral hygiene, we are able to score the items based on our clinical judgment, based on reports from the patient, from clinicians, from care staff, and or their proxy or family. So that's why those ANA codes really shouldn't be used very often, because even if the patient says they don't want to do something, if you have seen enough in order to make a clinical judgment based on what you've seen or what you've observed as to how that patient would most likely complete that activity, you are still able to score the Section GG item. So it does not necessarily have to be observed. We also want to allow the patient to perform the task as independently as possible, as long as it's safe. We have all seen those patients where they say, oh yes, I'm able to get dressed independently, or I'm able to get on and off the toilet just fine, but it is definitely not safe. And so safe is a key word here. So just because a patient may be able to complete it independently, if it's not safe, you need to score it based on how the patient will be able to complete it as independently as possible, as long as it's safe. If assistance is required because the patient's performance is unsafe or because of poor quality, the score should be adjusted to the amount of assist that was required. Device use does not affect coding. So if the patient requires a walker, provide them with the walker. So a device use is incorporated within all those scoring items. And so whether or not someone uses a device, it shouldn't adjust it. So there's no independent versus modified independent. So if they use a device, but they're independent, you would still score them as independent. Score based on their usual status. This is also really important and why it's valuable to have multiple clinicians giving input into section GG, because you want to observe it in different locations and circumstances, right? Some patients may be doing really great in the morning and then not so well in the afternoon. And so you just want to make sure that the scores are based on their most accurate or most usual function versus only when they're doing really well or only when they're not doing well. Because if we're only scoring them on one end or the other, that can provide inaccurate information on section GG. So that's why it's helpful to have multiple clinicians score the same items on the same patient so you can get a better idea of their usual status. And then you want to base scores on baseline status prior to benefiting from therapeutic intervention. Now, some facilities have taken this line to interpret it to mean that therapists cannot score section GG, and that is absolutely not Medicare's intent. What they don't want, though, is for therapy to go in and provide multiple assessments and then score section GG, because then at that point, they're not really a baseline function. And so this was kind of even how you would score the FIM, right? It was without providing a lot of teaching and education. Now, if the patient requires cues in order to do things safely, that is built into the scores. And so even though you might be providing an education of, put your hand on the walker and one hand on the bed, don't pull back on the walker, even though that's an intervention and it's education, if it's necessary for them to perform the task safely, that's okay to provide that cue that's built into that scoring. And so this line is not meant to be interpreted that therapists are not able to score section GG, because we absolutely are. So some interesting notes for self-care when we're scoring section GG, and this is why it's really important to read through the description, especially if you aren't familiar with these items or you don't score them very much. They have very specific instructions on what is or is not included in the task that may be slightly different from how we normally think about the task as an occupational therapy practitioner. So bathing, it does not include washing hair. That's a separate item. Upper body dressing, it includes bras, dresses, TLSOs, abdominal binders, etc. So you can't just score it also on a hospital gown. And so if a patient normally has to wear a TLSO, you would score upper body dressing, including their ability to don that TLSO. Or same thing if they wear a compression garment on their arm. That is also included in upper body dressing. So whatever it is that they normally have to be able to wear, you would include that in upper body dressing. It's not just their ability to put on a shirt. Lower body dressing includes donning lower limb prosthesis, knee braces, compression stockings, shrinkers, etc. So you need to include every single item in that lower body dressing. So let's say the patient's able to put on their underwear without assistance, but they need assistance donning their compression stockings. You would score that lower body dressing item based on the complete task. So including compression stockings with the underwear. Toileting includes the ability to clean and use an ostomy, but does not include changing the ostomy bag. So that's another important note. And if they have an indwelling and catheter, you score based on the assist required for the bowel movement. So you can still score toileting even if someone has an indwelling catheter. And then footwear also includes an AFO as well as compression stockings. So it's really important to look at the nuances of these items to ensure we're scoring them accurately, because the last thing we want to do is score someone as more functional than they actually are, especially on admission, because if CMS adjusts payment based on that patient's functional status, if we score them as too accurately, not only are we harming the facility in that they're not receiving accurate reimbursement, but we're also harming the patient because now the facility isn't able to afford the services that that patient medically requires because we provided an inaccurate score. So these are some of the questions that I received through the Q&A submission. So this was a really good one. If someone is NPO, would they be scored as NA due to medical condition on the self-care eating item? So what about if we work with a patient who has the ability to manage and care for their feeding tube? And so this is taken directly from the OASIS e-guidance manual. It's the same guidance on all these section GG items, but so assistance with tube feedings or total parenteral nutrition or TNP is not considered when coding the eating item. So eating is only considered when ingesting food by mouth. So if it's a new or recent onset medical condition, you would say 88, not attempted due to medical condition or safety concerns. But if they used TPN or a G-tube before their current exacerbation or illness, it would be coded as 09, not applicable. Now, if the patient eats and drinks by mouth and relies partially on TPN or tube feedings, you would code eating based on the amount of assistance required to eat and drink by mouth. And then here's another one for toilet hygiene, another great question. So if they have a chronic Foley catheter and ostomy device, how do we score toileting? So again, ostomy includes wiping the opening, but not managing the equipment. So only their ability to empty and manage that ostomy, but not the ability to remove and replace and all that. So it just involves that little piece. If they have an indwelling Foley, but they still have bowel movements, you code this based on the type and amount of assistance needed by the patient when moving their bowels, which may also include perineal hygiene to the indwelling catheter after the bowel movement. And CMS does state as well that you do not need to observe the patient having a bowel movement in order to accurately score toileting. This is another area where you can utilize your clinical judgment. And so, and this is another great question. I'm using this with students. I want to learn how to teach it in ways that are practice-based. And so the nice thing about Section GG is it is a functional assessment. So you can use AOTA's Section GG handout, which I'm going to pull up here next. Providing case scenarios is another great way to have students practice scoring this item, because if they're going to be working with adults, if they're going to be working in post-acute care, they need to know how to score Section GG. And so CMS has multiple different case scenarios built into their guidance manual. So if you don't want to work harder and you want to work smarter, just use their case examples and have the patient or have the students practice scoring them. And then you can also educate on the role and importance of this tool, because it does influence reimbursement. And the fact of the matter is, if our facilities aren't getting paid, they can't pay us. So if we're responsible for scoring these items, we want to make sure they're accurate, not only so that the patient receives the services that they require, but also so that the facility can afford to pay the clinicians who are needed in order to provide those services. And so while we're here, I want to show you the AOTA Section GG handout, which is probably one of my favorite resources to refer to. So I already have the webpage pulled up here, but the shortened URL is aota.org/Section GG. It's also included in the PDF of the handout that I provided you. And I like this page because it has a lot of great resources. So it talks about what Section GG is. It also has links to all the post-acute care assessments where Section GG is built into these assessments. It has information on how to score them, but this handout right here is my favorite. I go here because it's such a quick resource to find the information versus trying to dive through the IRF-PI or the OASIS to find each individual item. So this is a really great summary. And so AOTA has this form. You can either fill it out and print it out, or you can print it out and use it in your facility. Obviously, be careful with any patient identifying information up here. You want to make sure you're still compliant with HIPAA policies, but this is another great way for clinicians to collect information. So let's say your facility, for whatever reason, doesn't allow OTs to score Section GG. You could still collect this information on your own, collect it at admission and discharge, and that's a good way to demonstrate the objective value of occupational therapy, as you can say, hey, I influence these positive outcome measures, and use that as an advocacy tool to increase the referrals for OT services. And so as you can see here, they have built in the admission, the goal, and the discharge score. So if you're scoring on admission, generally going to be setting the admission as well as a goal score. And then also you can see here, it includes the definition as well as the scoring items. So it includes all the different scoring options, the definitions of every single option. Now the guidance manual as well as the other manuals have a lot more detailed information on how to score each item, but this is a really great summary to keep with you. And then you'll also see that we have the little asterisks. And so down here, it tells you which items are not currently used in long-term care hospitals. So, right, you may notice that all of these items from E through H are not currently used in long-term care hospitals. So long-term care only uses these, or LTACs only use these top 4. Or same thing like here, wash upper body is not used in the other PAC settings. It's only used in LTACs. Down here, we also have the section GG mobility items. So when AOTA updated this handout this year, they added in the mobility items. So it's great to have those through here. So you can see there's specific instructions, only score these items if the client's walking, versus only score these if the client uses a wheelchair. If they do both, then you'd probably want to score all of them. And within the systems, they have built in whether or not they use a manual or a motorized wheelchair. This is also another great resource. It's basically just a decision tree, which is based on CMS's decision tree, but it's a little bit prettier, of how to score these individual items. So it helps ask you questions, did you help complete the activity? Yes or no. So it helps you walk through that scoring, a little bit more spelled out explanation of how to score, and then additional resources. So this is probably, again, one of my favorite tools every time I'm looking up something about section GG, or I need to remember what the definition is of, oral hygiene. It's all right here. It's easy to access, and it's nice that they have that vanity link that's able to take you directly to this handout so you can find it quickly, because sometimes navigating a website is not always the easiest. So definitely highly recommend using this with students, or if you are a practitioner. Hopefully it's built into your medical record, but if not, it's just another great way to track your outcomes with your patients. All right. So in here, we're getting into some of the Q&As that I received. So thank you everyone who sent in Q&As. I still see MinAssist used in documentation. What is the reason for taking out MinAssist as a level of assist in section GG? So we can still use MinAssist within our documentation, still score the way you would normally throughout, how you normally would in your evaluation. That's totally fine. CMS decided not to include it. Section GG is primarily used, again, for outcome measures and reimbursement. And I believe through their research, they found that there really wasn't that much of a difference between like your contact guard, min, mod, max. And so that's why they just removed the MinAssist level and kept it as that less than 50% or more than 50% assistance. But you can absolutely, score someone as whichever level is appropriate, and then in the section GG, and then use your normal therapy scoring of that standby, contact guard, min, mod, max, dependent, in your normal therapy documentation. So MinAssist is still utilized by therapy practitioners. It's just not utilized in section GG scoring. How can a mobile Part B private practice owner leverage section GG as a tool to contract with post-acute care rehab to complete home evaluations? I thought this was a fantastic idea and a fantastic question. I think the primary places where you'd have good success in leveraging section GG scores would primarily be in inpatient rehab and SNF, because it directly impacts reimbursement and outcome measures. It's not used in home health to influence reimbursement or outcome. The OASIS items are still used versus section GG. But the one way you could kind of leverage this is say, hey, by providing a home safety evaluation, they might be able to have better outcomes. It's another touch point. And so basically kind of tying it back to what are those facilities' goals. Another facility goal through their quality measures is discharge to community, right? So by having a home evaluation before that patient discharges can hopefully create a better successful discharge to community, help reduce hospital readmission. So even if you aren't able to leverage section GG directly, you're still able to look at those quality measures and talk with those post-acute care facilities to kind of figure out what their goals are, what's impacting their bottom line, and how you can help them meet those goals is a great way to kind of leverage some of these assessment items and these outcome measures in post-acute care as a private practice clinician. I work in SNF and want to act as a better advocate for my patients when it comes to receiving services. Where do I start? This is a fantastic question. One thing I always recommend is learning how reimbursement and outcome measures work within your setting, because everything is so heavily driven by reimbursement, and that's what heavily influences the goals of where you work. If you can understand how the reimbursement system works, it also allows you to identify when policies are incorrect or misunderstood. There is a lot of misinformation out there about what Medicare does or doesn't cover, whether or not groups are required under PDPM, all sorts of kind of information out there that's floating around. I see it on Facebook every day. I see it from other practitioners. So understanding and learning accurate information on how reimbursement and measures work within your setting is a really good place to start. So that way you can identify if someone says, Medicare only covers a 30-minute visit, you can say, I know that's not true based on the information that I have directly from the source from CMS. And so that's a great way to start advocating. You can also look at your facility's quality measure outcomes publicly. It's on Care Compare. And so that's another great way where you can look at your facility, look at their quality measures, and most of them are function and mobility based. And so you can look at those measures and say, hey, I noticed that we don't have the ideal outcomes in these areas. Here's how occupational therapy can help, which can help you then get more access to your patients. And so using those skills that you already have as a clinician, thinking about what are their goals, what are the barriers and supports, but applying it to getting access to patients is going to help you understand where in your facility are there barriers to getting access to these patients, where are there something in place that's supporting access, and how can you use those skills to navigate that situation. But understanding the complete picture and reimbursement and policy is really going to help inform those decisions and help back up your arguments. Is Section GG similar to a modifier like the KX modifier? No. So Section GG is a standardized assessment versus KX modifier is a billing modifier that's used for therapy thresholds, primarily in Medicare Part B, but also may be used by private insurers. Section GG is only required by Medicare, but in some of these settings, the admission assessment is required on every patient. So in skilled nursing facility, you have to complete the MDS on every single patient, regardless of payer. That's the only setting currently that's implemented that, but in inpatient rehab facilities, that will start happening in 2025. I believe that the IRF-PI will have to be completed on every single patient. That was included in the inpatient rehab final rule for fiscal year 2023. And then it's proposed in the home health final rule for calendar year 2023 that the OASIS will be completed on all patients. The final rule hasn't come out yet, but if it was finalized in inpatient rehab, we can assume it's going to be finalized in home health. And I believe the date is also on 2025 as well. So soon in all these settings, Section GG is going to be required on every single patient. So it's a standardized assessment that Medicare is requiring. And it's also something that researchers are using to look at the impacts of therapy. So another reason why GG is important. And when is it ideal to use GG to get maximum benefit for both the patient and the clinician? I think there's a lot of different opportunities. A lot of it is identifying accurate reimbursement, because again, if a patient is being scored as too functional or if their information isn't accurate on these assessments, facilities aren't going to receive accurate reimbursement, which means they're not going to be able to appropriately pay for the services that patients require. And we know that oftentimes patients are scored as more functional than what they may actually be, especially if someone's not actually observing that assessment. So I think it's a really great opportunity to advocate for the role of occupational therapy in scoring these assessments because of our expertise in function, cognition, and mobility. So I know SNF and inpatient rehab are using Section GG. What about home health? Yes, it is fully used in home health. It's built into the OASIS. What makes home health different is that Section GG does not influence reimbursement or quality measures in home health. I can't explain why. I'm not sure why CMS hasn't made that change. I don't know if they're just waiting until they someday come up with their standardized post-acute care reimbursement. That's something they've been working on since 2014. So who knows when we'll see that. But I'm not sure why CMS has yet to use Section GG in outcome measures and reimbursement under PDGM. But under PDGM, they are still using the OASIS M1800 sections primarily for those outcome measures, including value-based purchasing. But in inpatient rehab and SNF, it does influence reimbursement and quality measures. So even though Section GG is built into the OASIS, it doesn't influence the same things like it does in SNF and inpatient rehab. So since GG is more vague than the FIM, is there direction on the less than half, more than half, or are people using FIM breakdowns of tasks to guide them? So definitely don't use the FIM breakdowns of tasks. It's a completely different assessment. You want to take Section GG at its word. And so CMS, again, in these guidance manuals has really clear information on how to score each individual item. I did include a link to the draft OASIS E guidance manual. In chapter 3, it has great explanations for every single section or every single item and how it should be scored. And so I encourage you to look at that. CMS also has really fantastic free training on how to score all of these items. I included links to those in the handout. So definitely take those and use what CMS tells you, because they really did a good job of thinking through the different scenarios and then use their guidelines to score Section GG. I would not use FIM guidelines to score Section GG, just because it's a completely different assessment and has a different way of breaking down this information. But that's not to say that you can't still use the FIM in your own clinical practice. I just wouldn't use them to score one or the other. So how do I fill it out? PRN at various facilities, and I get told different things. So always go to the source. So obviously AOTA's handout is a great summary, but I highly recommend taking the CMS trainings that are, again, absolutely free on how to score every single individual item. So that way, you know that you're getting accurate information. It is definitely, especially in facilities, it's a lot of, well, my boss told me this, who told me that, and it's kind of a long game of telephone. It's a lot of hearsay, a lot of guessing. And so if you always go back to the source, you know that you're getting the most accurate information, which the source in this case is CMS, the Centers for Medicare and Medicaid Services. So by using their free resources, I also included quite a few like YouTube trainings, both for LTAC inpatient rehab as well as home health. They released new YouTube trainings that both of them are like an hour long. So really comprehensive explanations of how to score these items. So even though it takes a little extra time, I would definitely use those to educate yourself to make sure that you are scoring the information accurately, and then potentially also show them to your employer so they can help educate other clinicians as well. So how is Section GG used for reimbursement through the therapy process? So the primary ways is that it influences either risk adjustment, or some of these items are used to determine the functional impairment. So under PDPM, a subsection of Section GG items, so it's not all of them, it's 3 self-care items and 7 mobility items are utilized to come up with the functional score, which is then used to determine the per diem payment for OT, PT under PDPM. For that case mix. And so in inpatient rehab as well, it's also used as part of that case mix calculation. And so that's the primary way it influences reimbursement in those settings through the therapy process. So that's why it's important to have, in my opinion, therapists be scoring Section GG, because we are able to more accurately score them based on our clinical judgment, our expertise, and observing the task. So you're kind of able to kill 2 birds with 1 stone. You complete your therapy evaluation as well as completing Section GG. Just by having the patient do what you would normally have them do. And that way we can help facilitate accurate reimbursement for our settings. So other opportunities to learn more about this information, I have the Amplify OT podcast, which is completely free on any platform, articles. I'm going to have another webinar in October. I have not yet picked the topic. So if you have a topic that you would like me to talk about, send me an email, let me know, and I'd be more than happy potentially to do something on that. I also send out monthly advocacy updates through my email. And I also have a blog post that's pinned on my articles page that it's the same post that I update every single month with advocacy updates, different things that are going on with CMS, all that sort of stuff. I also am excited to announce that I'm launching my Mastering OT Policy and Medicare course. The doors will open to the public October 10th, but for people who are on the wait list, you will get a special opportunity to sign up on the 9th, as well as a special freebie for signing up on the 9th. So that's my comprehensive Medicare course, kind of the thing that I wish that I had gotten when I was a new grad, to learn all about everything that's going on in Medicare and health insurance and how it all fits together. I'm going to try and include this Section GG webinar in there, so that way people have a more in-depth understanding of how it works, but just really talking through all the reimbursement, because the best thing that helped me understand my role working in acute, working in home health, was understanding how the system actually works, right? You wouldn't try and drive down the highway without learning to drive first. I think it's the same thing in healthcare. We shouldn't just be trying to kind of blunder our way through healthcare system, especially because it's so complex. So that's the link there. All right. And this is my information. I'm on pretty much every social media at Amplify OT. Most of them have an underscore between Amplify and OT. You can also find me on my website, and that's my email. I see a couple chats to do one on the Mental Health Parity Act, Medicare coverage for OT, psychiatric diagnoses. So yeah, lots of different stuff we can talk about in future webinars. I'm going to try and record some podcasts on some of the different bills that are coming up. The nice thing about Part B is that Part B, you can still covers therapy as long as it's medically necessary. You just bill the normal codes, even if they have a psychiatric diagnosis. Obviously, there's lots more information out there, but Part B does cover OT for mental health services. So just lots of different things out there. Yes, I agree. I wish they taught all this stuff in OT curriculum because it's so important, right? And it's hard because when we go out there with our to our employers, I never got training on which eval code to pick or what a CPT code really was or what it meant, or what what PDPM truly is and how it impacts my practice. Employers just kind of give you enough information to get started, and then you kind of learn word from mouth and on Facebook. And so I always try and go to the source. I link CMS documents in all my articles and in my podcasts. So that way, that the information is accurate, because that's how I learned. I learned by reading summaries that other people had written and then actually going to the source to read them, because it is a bit of a learning curve to try and figure out what it's saying. So what I always found helpful is reading it and then going back to the source. So does anyone have any questions? I'm going to go ahead and close my slides so I can see you all again.
What's sort of a worst case scenario of using GG code super incorrectly, or where it would really super compromise reimbursement for a building? Like, what would be the worst case scenario of that happening?
Worst case scenario is when facilities alter Section GG in order to optimize their reimbursement, and then they get sued for false claims, which is happening currently.
And what could happen where maybe it's even an accurate picture of how you're assessing a patient that's fluctuating a lot with medical status changes? What would make it look like that?
So if there's lots of inconsistent reporting, so like the Section GG scores don't line up with the therapy documentation, or they don't line up with, the patient reports, the number of therapy that's provided. And so CMS does kind of look into those things, right? They have access to all that documentation. And so, if the patient is scored as maximum assistance across the board, and then the OT comes in the next day and scores them as independent, but there's no explanation as to why that might be, right? There's no kind of explanation as to why there might be, because we know there's patients who are inconsistent, that have different functioning, whether it be because of a psychiatric diagnosis or because of their condition, or they may have like a Guillain-Barré that gets worse over time, right? But that should be evident within the documentation. So that's why it's important to document what we did and kind of justify those scores. And so, worst case scenario is that the information doesn't look accurate and CMS rejects the claim because they think the information is inaccurate, and then the SNF doesn't get paid, or they're scored as too functional or something like that, and then the quality measures and reimbursement doesn't adequately reflect the patient's actual condition or the care that's being provided. So researchers do use Section GG scores because they're publicly reported. Like CMS collects all that data, and you can get that data from CMS. But yeah, there's lots of different ways that people have tried to manipulate GG, which is why we have like PDPM instead of the old RUG system. But as long as your clinical documentation makes sense and kind of justifies why there's that inconsistency, then it shouldn't be as much of a concern.
Yeah, I've been a little bit concerned. My company has shifted to our net health documentation boxes to being reporting Section GG levels, which don't always convey the nuances of progress that we make with clients, because they're a broader category of, like you were saying, it's optimized for the reimbursement components. But where we might be making progress in therapy, or where there might be regression, it has a lot to do with the contextual features, how you're adapting the task, what cues were present in the environment or not present. So you can have somebody that's performing at a partial to moderate assist level with therapy staff, but maybe dependent max assist with nursing staff that aren't utilizing the cues and the environmental support. And that's a big part of conveying OT skill in adapting the environment and the task. So I'm nervous over time that how they're setting up the documentation to not capture those nuances that maybe I think we have to be looking at. How does OT reflect its skill, and when did they do go back in to see what was changing if we don't have that spot on the form? And I would just be curious, I know this is a broader conversation over time, but how we can start showing where, often in SNF and post-acute, we are working with folks that have co-occurring mental health and psychiatric diagnoses. And that's something that I think it's likely common, or at least I've experienced getting pushed back within post-acute settings. And I know the practice framework really wants us to really take into account all those client factors. in addressing how we're making progress. And it seems like it would be important to capture where our work is targeting those aspects of occupational performance. And it would be nice to get guidance from you as a policy specialist or from AOTA about how we should be setting up our daily documentation to acknowledge when our services are having an impact on those folks that maybe have dementia, bipolar, schizophrenia, anxiety, depression. And also I heard that depression is one of the case mix with PDPM. And I wonder if that means what that could mean for OTs to be of particular value to some of our settings that are looking at. I don't really know what it means that depression is included in that case mix.
Yeah, so there's different factors within PDPM, and I did link an article in my handout, which let me share that handout again, that link. That kind of talks through how reimbursement is based, but clinical categories and comorbidities is one of the case mix adjusters because basically CMS will reimburse more for some patients and reimburse less for others, right? Like a patient who only has a total knee replacement, otherwise doing well, no comorbidities, CMS is going to pay less for their care than someone who has dementia as well as a stroke and then also fell last week and broke their hip, right? They're going to require a lot more services than someone who's more simple. And so they kind of adjust their reimbursement that way. But yeah, I think, and it's all kind of about how we set up our medical records. So like Section GG is obviously never going to collect all the nuances of a patient. It's just supposed to provide a quick snapshot. And the hard part with some of these assessments is they have to be able to be scored by multiple clinicians. So it has to be able to be scored by a nurse, an OT, a PT, a speech therapist, whoever's completing that assessment, which makes them a little less nuanced, but that's where there's opportunity within our evaluations and within our daily documentation to kind of justify what's going on. And if there's not an opportunity to do that in our medical record, that's an opportunity to kind of advocate with our boss and say, hey, it'd be really great if we had a text box here where we can record some of that information and those sorts of things. Because I know we were able to make some adjustments to our medical records if there wasn't a checkbox or something like that we wanted. But that's an ongoing conversation of how, so Section GG is great, but it's definitely not an entire solution. I think it's an opportunity, but it's definitely not a solution for all of our patients' problems. Do we have any other questions? I really appreciate you all attending. I will most likely get the recording out to you. It'll probably take me a few days, so probably next week is when I'll send that out and you'll have access to it for free for 30 days. Feel free to send me any questions or anything like that. But if you guys don't have any other questions, then I think I'll just let you get on with your day.
I have like a not relevant
go
question
ahead.
to TG. Do you happen to know offhand, or is this something that you might consider doing some research into? Like, is the case mix for depression, is that reimbursed at less level? Are they not wanting to track that? Is there incentive not to track that at the post?
That I'm not sure of. And so you can, I can't remember off the top of my head all the different clinical categories that are included within PDPM, because it's a little bit different with PDGM, where I'm a little more familiar with the home health than PDPM, but okay. It just depends. So like PDPM and PDGM, they're really adjusted based on like multiple client factors. So they might reimburse a little bit more for someone with depression than someone without it, but it really depends on everything else they've got going on. Perfect. Well, thank you guys so much for attending. If you come up with anything afterwards, just send me an email. I'll be happy to provide you with resources the best I can. But thanks again so much for attending. I really appreciate your all's attention and have a fantastic rest of your day.